Thank you for joining today's webinar hosted by Hologic, shedding light on the realities of evaluating and managing preterm labor. My name is Susan Hepworth, and I will be facilitating today's webinar. Today's agenda is as follows. After my brief welcome and introductions, we'll be pleased to hear from Dr. Gabrielle Cassir, OBGYN and MFM, and Assistant Professor, McGill University in Montreal, Canada. Following Dr. Cassir's presentation, we have allotted time at the end for Q&A. And then following the Q&A, that will be the conclusion of today's webinar.
So hello to all, I guess good morning or good afternoon, maybe good evening for some. Whether you're joining from the comfort of your home or from your obstetrical units, maybe a beach somewhere or a lunchtime room, I thank you very much for tuning in. So let's dive into it, okay? Shedding light on the realities of evaluating and managing preterm labor. Disclosure, I do engage a bit in speaking and consulting on behalf of Hologic. Now let's go over the objectives of today's talk. Review the incidence and etiology of preterm birth, detail the reality of preterm labor, evaluate evidence-based data on fetal fibronectin, or FFN as the company likes to call it, transvaginal ultrasound, and their role in evaluating preterm labor. Let's then move on to assess the importance of reducing the number of false positive diagnoses. 5, let's exemplify the importance of timing when it comes to interventions that can cause an outcome of neonatal, that can improve neonatal outcome with a particular attention to antenatal corticosteroids. And 6, let's discuss the effect of protocols on patients with preterm labor. So before we begin, what I want you guys to know is that preterm labor is the #1 cause of triage visits around the globe. If we dive into a few statistics when it comes to preterm birth, we're going to start in my home country. So in Canada, preterm birth occurs in about 8% of pregnancies. It costs the Canadian healthcare system over $8 billion per year, so you can understand the significant economic burden of prematurity, and equates to about 375,000 births annually. It led to the creation of the Canadian Preterm Birth Network, so a study protocol for improving outcomes for preterm infants and their families. The goal was collaborative efforts to create programs, projects, partnerships focused on improving outcomes of preterm neonates. And I think the goal coming to you today is to do just that, get the word across, and really focus on the proper management of preterm labor. So preterm birth across Canada, you can see here that over the last several decades, we have seen a slowly rising rate of preterm birth. And that's true whether you're in a metropolitan province or a more rural area. If we turn to the US, so approximately 550,000 preterm infants are born annually. And this equates to 10% of all live births. And almost 3% of those are born below 34 weeks. As opposed to Canada, you guys in the US have been a bit more consistent over the last several years, and you've had a pretty steady rate of preterm births. Worldwide, so the incidence of preterm birth is estimated to be comparable to the US, approximately 10%. Now that ranges from 5% in parts of Europe to about 18% in parts of Africa. And approximately 15 million children are born preterm each year. 85% between 32 and 36 weeks, 10% between 28 and 32 weeks gestation, and about 5% below 28 weeks. So how do we define preterm birth? So this refers to a delivery that occurs between 20 and 37 weeks of gestation. Now we know that 70 to 80% of preterm births are spontaneous. Oops, sorry about that. And the remaining 20 to 30% are iatrogenic. Now, how about we stratify the proportion of preterm birth by etiology? If we do so, you see here, which is going to be the focus of our talk today, spontaneous preterm birth is a cause in about 30 to 50% of cases, followed by premature preterm rupture of membranes in 5 to 40%, multifetal gestation, preeclampsia/eclampsia, antepartum bleeding, and fetal growth restriction. Now, there are definitely multiple pathways that lead to preterm birth. So this may be due to inflammation or infection at the choriodecidual level, or maybe at the systemic level. This can also be due to decidual hemorrhage in the case of a placental abruption. Premature activation of your maternal fetal HPA axis because of a maternal or fetal stress, or maybe because of a pathologic uterine distension. In the case of multifetal gestation, polyhydramnios, or a uterine abnormality maybe. So there are numerous risk factors for preterm birth. This is by no means a complete list, but what we do know is that a history of spontaneous or indicated preterm birth is the major risk factor for recurrence. And recurrences usually occur at the same gestational age. A history of abortion by means of a D&C or a D&E are also risk factors. We also know that preterm birth is more prevalent in certain family pedigrees and in certain racial groups, in women who were born preterm themselves, or in women who maybe have a family history of a relative who had a preterm birth. Extremes in maternal age are also something that we should consider. And that may be due to either physiologic immaturity and maybe socioeconomic factors in younger moms, maybe the increase in comorbidities and obesity in those who are maybe a bit older. Uterine malformations, a history of LEAP, chronic medical conditions. So that can be chronic hypertension, diabetes, autoimmune conditions, renal insufficiencies. These are all things that increase our risk of preterm birth. Now, vaginal bleeding in the early pregnancy is often due to a decidual hemorrhage, and this increases the risk of both spontaneous and indicated preterm birth. So I think that's also important to keep into account when we're seeing our patients. Short cervix, an infection. So an infection can be an asymptomatic bacteriuria or maybe a genital tract infection. Short pregnancy intervals, smoking, and substance use are also risk factors. But interestingly enough, what studies have shown is that 2/3 of preterm births actually occur in women who have no evidence of risk factors, just complicating the management of these patients. So how do we counsel patients with a history of spontaneous preterm birth? So the risk of recurrence prior to 35 weeks is about 16% in women with one previous spontaneous preterm birth. That risk is then 41% in those who have a history of 2 previous spontaneous preterm births, and the risk goes up to almost 70% in women with a history of 3 previous spontaneous preterm births. So as we had stated before, preterm labor in itself, if we focus in on the major risk factor for preterm birth, is one of the most common causes of triage visits, but is also one of the most common reasons for hospitalization among pregnant patients. So what is the reality of preterm labor? What we know, and this is a really important stat when it comes to managing these patients, is that 50% of patients hospitalized for preterm labor actually end up giving birth at term. And less than 10% of women with the clinical diagnosis of preterm labor actually give birth within 7 days of presentation. So what this shows us is that we're really not doing a great job at estimating who is going to deliver preterm. And this leads to an overdiagnosis in about 40 to 70% of patients. And what happens is these patients then get triaged into trials of agents to try and arrest their contractions or stop their contractions, when in fact, these patients aren't really at risk for delivering preterm. So determining who is truly at risk of spontaneous birth is challenging. And that is primarily explained by the fact that symptoms and signs of preterm labor commonly occur among normal women who will ultimately simply end up delivering at term. And because a vaginal exam in the very early stages of preterm labor, so meaning at a cervical dilation of less than 3 centimeters and effacement of less than 80%, is not a very highly reproducible exam. So let's create a little roadmap. Let's first determine the methods for preterm labor evaluation. Let's understand the data behind each method to select the most reliable method or combination of methods. Then let's manage our patient. Let's understand the importance of correctly diagnosing patients. 3, let's implement best practices. Let's discuss practical knowledge and tools for implementing preterm labor assessment. So how do we evaluate preterm labor, and do we typically always do it in the same fashion? So 1, we can take a history and identify facts about our patient, risk factors. 2, we can question her on symptoms, figure out if the patient is contracting, if she has any evidence of vaginal bleeding. 3, we can perform a physical exam and determine her cervical dilation. Now that one seems to be the one that is probably the favorite for most and tends to be the one that a lot of physicians or practitioners turn to. Now, how about we add in a biochemical marker like fetal fibronectin or a bioanatomical marker like cervical length? So I speak to a lot of physicians, nurses, midwives, residents, and a lot tend to focus on contractile activity. When you look here, this is in fact the worst marker of preterm labor, only increasing your chance of preterm birth by 1.8 folds. Vaginal bleeding in itself is a bit more clinically significant. And as we have stated before, prior spontaneous preterm birth is already a cause for concern. So as an MFN, we love ultrasound, and I can say here that a short cervix already places a patient at higher risk of spontaneous birth with a relative risk just close to 8. And as you can see here, a positive fetal fibronectin test confers an almost 14-fold increased risk of spontaneous preterm births below 32 weeks. So what are the characteristics of a good test? Now, let's say you have crushing, really bad chest pain and you go to the ER. The doctor there will most likely prescribe an EKG and blood work, and the blood work would include trop levels. And let's say your EKG comes back abnormal and your troponin levels are elevated, then you would be considered ruled in, meaning those tests had a high positive predictive value. And how that translates into the obstetrical world, they are really telling us what the probability is that the subject will truly deliver early and is used to guide our intervention. And on the contrary, a rule out test, which is the reason why fetal fibronectin was developed in the first place, is really useful for its high negative predictive value. So it tells us the probability that the subject really won't deliver early and allows us to confidently discharge those patients home. So let's focus in and look at those negative predictive values. So if a patient is presenting for preterm labor, she is most likely already contracting. So this negative predictive value is less useful. She is most probably already at a cervical dilation of 1 to 2 centimeters. So this is not that much more pertinent. Now, if we look at a patient who has a long cervix or a negative fetal fibronectin, both those in themselves have a relatively high negative predictive value. However, if we combine both tests, we tend to get better prediction. And that holds true with the combination of a long cervix and a negative fetal fibronectin. As you can see here with this negative predictive value combination, we have almost 0% of patients who will deliver within the next 7 days, allowing us to confidently tell our patients that we can discharge them, and there is less than 1% chance they will deliver within the next 7 days. So let's focus in on one of these modalities, cervical length. As you can see here on the left, this is a normal cervix, nice and long, assessed endovaginally. And on the other hand, we have here a short cervix with presence of a nice funnel. So what are some of the criteria for cervical length measurement? Well, one, the approach should be transvaginal. We should not be measuring a cervix transabdominally, passing through the maternal bladder and the subcutaneous tissue. Our cervix, as you can see here in the image, occupies 75% of the actual picture. The anterior and posterior diameter of our cervix should be equal. Very, very, very important, because this is often something that we forget and cervical lengths are taken this way. Our maternal bladder should be emptied, because what happens is your bladder will compress your cervix and lead to a short cervix and a false image. Our internal and external os and our cervical canal should all be visible. Our caliber placement, like in the image here, should be correct. And lastly, I mentioned this, cervical mobility should be considered, because if we took a poll of the audience and actually asked everybody how long each one spends actually performing a cervical length, I can guarantee you that the answer is, if we're all truthful, would likely be 1 to 2 minutes. When in reality, based on the CLIO program, which is the cervical length certification recommendation, we should be spending between 3 and 5 minutes performing a cervical length assessment. And I think that's perfectly exemplified with the patient below. So what we see here is on the left, a nice long over 4 centimeter closed cervix, right when the probe was introduced into the patient. Fast forward 3.5 minutes, and this is what you get, a short cervix at 0.5 centimeters with presence of a nice funnel and some sludge. So this here represents the potentially missed opportunity to intervene and help our patient, because this is a true dynamic cervix. So what are the strengths of our cervical length? So longer cervixes do correlate with a lower likelihood of imminent delivery and allows us to properly and actually visualize our cervix. The weaknesses, so the cutoff for a positive or a negative value differs immensely in the literature, which we will speak about a bit later, requires expensive equipment and trained users. And what most research shows when you look at the study is that even with well-trained users, up to 30% of images are still incorrectly taken. So fetal fibronectin, if we turn to that next. So fetal fibronectin is a test that should be performed in women with symptoms of preterm labor from 24 to 34 and 6 weeks gestation. Now, fetal fibronectin is an adhesive glycoprotein at the maternal fetal interface. And what happens is disruption at that interface, either by subclinical infection or uterine contractions or inflammation or placenta abruption, releases FFN into the cervical vaginal secretions and is the basis of its use as a marker for preterm labor. It is a common biomarker for all 4 mechanisms of preterm birth that I showed you on the graph before and provides a truly objective assessment. So a few precautions when it comes to FFN collection. So we should ideally be collecting our specimen prior to a digital exam or collection of culture specimens, and ideally before a vaginal probe ultrasound is used. And that's because any manipulation of the cervix can lead to a false positive result. We should not be testing our patients in the presence of moderate or gross vaginal bleeding, if there's an advanced cervical dilation, so more than 3 centimeters, and the presence of rupture of membranes. Now, another important thing, especially for our residents and students, I often kind of go over this when I'm in my triage unit, is we should not contaminate our swab with lubricant, because what happens then is 2 things. One, it can lead to a false negative result if the actual swab head is completely coated with lubricant upon introduction, or 2, can actually lead to a false positive result if the actual lubricant is added or dissolved with the specimen, with the solvent buffer with the specimen. So we really have to be precautious when it comes to using lubricant prior to doing an FFN test. And a little word on if patient has had intercourse in the past 24 hours. What we need to remember is a negative result is still valid. It is a positive result that may not be valid and should be confirmed more than 24 hours after the actual episode because semen does contain fibronectin protein and so can lead to false positive results. So as we had stated, fetal fibronectin is a highly effective rule-out test. What you need to know is that 80% of patients who test with fetal fibronectin will receive a negative test result. And a negative result ultimately means that a patient has a less than 1% chance of delivering within the next 14 days. So it is a very, very reliable and useful test to allow us to tell a patient that there is very little risk of them delivering within the next 14 days and allows us again to limit interventions that are maybe not necessary. So strengths and weaknesses of fetal fibronectin, one, as we have stated, is objective. It is reliably high negative predictive value for both 7 and 14 days. 80% of patients, like we said, will receive a negative test result. Can be used on both singleton and twin symptomatic pregnancies. The results are available less than 30 minutes after test initiation. Sample can be collected for free. And important also to know, so the sample is actually valid for up to 8 hours at room temperature and 3 days refrigerated. So a lot longer than initially I even thought. Weakness, sample must be collected prior to a digital exam if possible, and the precautions we had mentioned with respect to intercourse. So does combining diagnostic tools improve prediction? I think that's what we're here to kind of determine. So the answer to that is yes. And how does combining cervical length and fetal fibronectin actually work? So in patients with symptoms of preterm labor around the globe, a cervical length of less than 30 millimeters is considered a risky cervix. And that equates to about 1 out of 4 patients who will deliver within 7 days. Now, if we ask ourselves, can we heighten or lessen that risk with the addition of fetal fibronectin? And the answer to that question is also yes. As you can see here, adding the fetal fibronectin testing and getting a negative test results then makes that initial risk of 1 out of 4 pass to 1 out of 10 who will deliver within 7 days and allows us to discharge our patient. On the other hand, a positive fetal fibronectin makes that risk go from 1 out of 4 to 1 out of 2 for delivery within 7 days. So using fetal fibronectin adds prognostic information to cervical length, and FFN, in addition to transvaginal ultrasound, increases the prediction of cervical length, as we can see here, by 50%. So it definitely has added value to use the test in combination. So as we had kind of quickly mentioned before, I think what as clinicians and especially sonographers or OBGYNs or maternal fetal medicine specialists, the thing that is a bit more varying in the literature is what lower limit of cervical length should be used. Some people use 15, some people use 20, some use 25, and yet others 30. And I think the answer to that question is well answered in a study published in the Etiology by Gomez entitled "Who Benefits the Most from the Addition of Fetal Fibronectin to Transvaginal Ultrasound?" And the answer to that question is these patients right here. Patients in the gray zone for cervical length with a cervix between 15 and 29 millimeters benefit the most from the addition of fetal fibronectin. Now, the reason being is because those who already have a short cervix, less than 15 millimeters, already have a high probability of delivery within the next 7 days, just upwards of 56%. However, if you fall in the gray zone and have a negative fetal fibronectin, then we know that 95% of those patients will not deliver within the next 7 days, and again, allows us to confidently discharge a patient, as opposed to those who might be in that gray zone and have a positive fetal fibronectin and might warrant a bit more increased surveillance. Another study looking at that lower limit cutoff is actually an interesting prospective cohort study coming out of the Netherlands and showing results of 665 women. So what this test showed is that fetal fibronectin testing in cases of patients, again in this gray zone with a cervical length between 15 and 30 millimeters, allowed increased identification of women who were not going to deliver within the next 7 days, really stratifying those patients based on one, cervical length, and the fetal fibronectin coming back as negative. So I think for practicality purposes, really choosing a cervical length lower limit of 15 allows us to have that good triage when you have a cervical length as your basis. So as is true with most things in life, timing matters. And that holds very true when it comes to evaluation of preterm labor. Accurate identification of women in true preterm labor allows appropriate application of interventions that can improve neonatal outcome. Some of those interventions include antenatal corticosteroids, which we'll focus in on a little bit, magnesium sulfate for fetal neuroprotection, tocolytic therapy to stop our contractions and be able to administer antenatal corticosteroids, hospitalization and or transport to a tertiary care level who has appropriate newborn care, and GBS prophylaxis, let's not forget that. So in 2020, Cochrane had a review and meta-analyses, and this actually replaced the 2017 Cochrane review, included 27 randomized controlled trials involving just over 11,000 women and almost 12,000 infants enrolled from 24 to 37 weeks gestation. So compared with placebo or no treatment, what that Cochrane review showed is that antenatal corticosteroids reduced 1, perinatal death by 15%, neonatal death by 22%, respiratory distress syndrome by 29%, and intraventricular hemorrhage by almost 50%. So I don't think there's any controversy in the literature as to the benefits of antenatal corticosteroid administration in preterm, in very preterm patients. However, what we do know about antenatal corticosteroids is that benefit is only present if delivery occurs within 7 days of administration. And that's where things become a bit more complicated. So just as important, accurate identification of women not actually in preterm labor avoids unnecessary and sometimes costly interventions. I think it is something that is well summarized in an SMFM, so Society of Maternal Fetal Medicine, issued a statement in June 2022. And what they said is, although neonatal benefits begin to accrue in just a few hours, outcomes are best when maternal antenatal corticosteroid administration occurs 1 to 7 days before birth. In contrast, if the pregnancy is eventually delivered at term, several studies suggest the association of antenatal corticosteroids with adverse outcomes. So there has been a growing amount of knowledge suggesting that term-born infants exposed to antenatal corticosteroids are at increased risk for both short and long-term adverse effects, even following as little as a single course administered at any gestational age. So let's look at this study. Are newborn outcomes different for term babies who were exposed to antenatal corticosteroids? So this was an interesting study published in the AJOG, a retrospective cohort one, including 5,330 singleton term-born children exposed to antenatal corticosteroids at a mean gestational age of 32 weeks, compared with term-born children whose mother also had threatened preterm labor, but who had not received antenatal corticosteroids. So what this study showed is that antenatal corticosteroid exposed infants had increased odds of NICU admission and SGA birth rates. So this study is kind of pointing us to possible short-term adverse outcomes of administration of antenatal corticosteroids, and an ultimate term delivery. So a baby who does not deliver within that window of 7 days following administration and end up delivering at term. Now, in addition to the short-term adverse outcomes, there has been suggested long-term adverse outcomes when corticosteroids is followed by term delivery. And this is most often, and what is hypothesized, is this is due to an alteration in cortisone regulation. What we end up finding is a flattened daytime cortisone slope without the cortisol awakening peak. And this is associated with cognitive delay, mental health problems, and an increased risk of cardiac, metabolic, and autoimmune conditions. There has also been found to have a significantly higher cortisol reactivity to acute psychosocial stress, giving greater vulnerability to stress-associated conditions, including abnormal behavior, depression, and memory impairment. There has also been an increased risk of speech and language delays, which have been observed, scholastic skill disorders, motor function conditions, epilepsy, and even cerebral palsy. So this really leads us to be extra precautious when it comes to really considering when we should be and when we need to be administering antenatal corticosteroids. So let's look at this 2022 systematic review and meta-analyses entitled Evaluation of Long-Term Outcomes Associated with Preterm Exposure to Antenatal Corticosteroids. So this was the most recent systematic review and meta-analyses coming from one of the main gurus who already was involved in the ALPS trial, Kelly Murphy, who actually works at Mount Sinai in Toronto. And she and additional authors really combined the systematic review and meta-analyses of 30 studies of medium-term outcomes in more than 1.25 million infants born at or after year 2000. And what this study managed to show is that antenatal corticosteroid exposed infants born very preterm had a significantly lower risk of neurodevelopmental disorders, which is what we found in that 2020 Cochrane review. However, late preterm and term-born antenatal corticosteroid exposed infants had a markedly higher risk of adverse neurocognitive and or psychological disorders when compared with unexplained children. And I think this really shows the varying and differential results that come with on the basis of gestational age at delivery. So administration of corticosteroids at 34 to 36 weeks gestation has remained a controversial topic in that late preterm period, with clinical practice guidelines from different countries procuring varying recommendations. And this is due to likely very differential interpretations on the basis of benefits and harms of antenatal corticosteroids at a late preterm period. So this actually led the 2022 systematic review and Cochrane study, both led to the Society of Obstetricians and Gynecologists of Canada to issue new updated key messages, which were just published at the end of December 2022. So the key message were as follows. Administration of antenatal corticosteroids at late preterm gestation decreases the risk of neonatal respiratory morbidity, which is what we're not trying to necessarily determine or not, but it increases the risk of neonatal hypoglycemia, and that risk went from 15% to 24%, with a relative risk of 1.60, which was statistically significant. They stated that the absolute benefits of antenatal corticosteroids decrease with each advancing week in late preterm period, so from 34 to 36 weeks gestation. And they went on to state that the impact of late preterm antepartum corticosteroids on neurodevelopment or other long-term outcome remains unclear and uncertain and warrants more research due to the absence of direct evidence for these outcomes, taking into account certain confounding factors. SOGC actually went a step further and recommended a change in practice. They stated that antenatal corticosteroids should continue to be strongly recommended up to 33 and 6 weeks gestation when delivery is expected within 7 days. So that differs a bit from the upper limit that was previously established to be 34 and 6 weeks gestation. From 34 to 36 and 6 weeks gestation, antenatal corticosteroids should be considered based on absolute harms and benefits specific to the gestational week. And from 34 to 36 and 6 weeks gestation, steroids are not recommended for pregnancies complicated by pregestational diabetes, as this may worsen neonatal hypoglycemia. So this graph I thought was, this table, sorry, I thought was interesting because it was published in the new SOGC recent guidelines and really stratified the benefit reduction that is seen with the administration of antenatal corticosteroid based on gestational age. So you can see here, going from 34 to 35 to 36, same over here when it comes to respiratory morbidity and major respiratory morbidity, we see a decrease in benefit of antenatal corticosteroids as that time frame goes on. So I love this graph, and what I really wanted to point out is this point right here, 34 weeks, okay? When you start seeing an abrupt increase in the number needed to treat to prevent one case of respiratory distress. We can see here that the effect and the number needed to treat is kind of linear throughout these gestational ages. And then you have this kind of inclining, really tilting point at 34 weeks, so the number needed to treat to prevent cases of respiratory distress. So I think that's what leads to a lot of the consideration of the upper limit of gestations where antenatal corticosteroids benefits outweigh the risks. So what we know, a single course of antenatal corticosteroids in mother at risk of preterm delivery within 7 days is undoubtedly a life-saving intervention and is in keeping with best clinical practice. Now, I think the reality is the fear of failure to give antenatal corticosteroids to an indicated mother has caused anxiety among physicians and has increasingly led to excessive and unnecessary and sometimes suboptimal administration of antenatal corticosteroids. As we had stated, timing is everything in regard to efficacy, but in this particular case, also in regard to safety of antenatal corticosteroids. So let's get back and finish off with the topic at hand. As we said, preterm labor, how do we manage these patients? And the ultimate goal is if a patient is not truly in labor, how do we confidently and can we confidently discharge her home? Out of all the slides I presented, I will say this one is my personal favorite. It actually is a table graph, that came out of 2017 large US national database. And what I want you to remember today, or next time you are in your triage units, is you will ultimately discharge 3 out of 4 patients who come to your triage units with complaints of preterm labor. Now, out of those 3 out of 4 patients you will discharge, 20% of those discharged from a sophisticated medical healthcare system will come back and deliver within 3 days. And so there lies the problem of us discharging patients and a good substantial number of those patients coming back and delivering within 3 days. What this graph shows right here is that we are just not doing a great job at implementing the proper methods to evaluate preterm labor. As I have shown you earlier in the presentation, we should be using a combination of transvaginal ultrasound and fetal fibronectin to properly assess our patients presenting for preterm labor. However, in reality, what we see here is that 78% of patients had no evidence of fetal fibronectin or even a transvaginal ultrasound on examination and review of charts. Actually, in fact, only 1% of those patients actually had the combination of a transvaginal ultrasound and fetal fibronectin. So I think the reality is we should be doing a better job. Our patients deserve a bit better on a clinical management perspective. So what explains a bit of this haphazard approach? Well, one, providers have autonomy and are kind of independent practitioners. There is no real oversight or enforcement. Nobody's coming to your triage units and saying, why aren't you using cervical length or fetal fibronectin, or why aren't we following a certain algorithm? We all have different levels of training and experience. We all have at the basis different levels of concern. The research is not linear and is often conflicting, and there is no really established standard of care. And so this where I think some of the focus could be geared on a hospital perspective is trying to figure out how to establish a certain standard of care. And what are some of the potential benefits of a preterm labor evaluation protocol? Well, one, we know that a negative evaluation decreases maternal admissions, decreases length of stay, avoids maternal transfer to have to go to a tertiary care and ultimately not deliver preterm, is cost saving for both the patient and the healthcare system, and has immense emotional and social benefits for the patient. On the contrary, a positive evaluation, as we have shown, allows us to target intervention to higher risk patients. So how does a protocol get implemented, and how do we follow, and how should we be following a protocol? So this is a study entitled Cost-Effective Standardization of Preterm Labor Evaluation. It's actually a really interesting study coming out of the Mayo Clinic. We all know that the Mayo Clinic is one of the very known referral centers in the US. And what this study did is actually, in a residency program, enforce a protocol and enforce the follow of a standardized algorithm. And this here is the actual algorithm that got implemented in the Mayo Clinic. So as you can see, if somebody presented for symptoms of preterm labor and was found to have a cervix above or equal to 3 centimeters dilation, or more than 80% effacement, well, that patient was admitted to labor and delivery. Consideration was given to tocolytic therapy and antenatal corticosteroids and GBS prophylaxis. Now, on the contrary, if this scenario did not occur, she had a cervix at less than 3 centimeters, a transvaginal ultrasound was recommended and performed. In a transvaginal ultrasound, you were found to have what we had stated in the beginning in the Gomez study, a cervical length of less than 1.5 centimeters. Then that patient was admitted to labor and delivery, and institution was given for tocolytic therapy and antenatal corticosteroids. However, if your patient was in that gray zone, like we had described in the literature, between 1.6 and 2.9 centimeters, that's when fetal fibronectin testing became useful. If the patient had a negative fetal fibronectin testing, then she was discharged home with no consideration of antenatal corticosteroids or GBS prophylaxis. However, if she was found to have a fetal fibronectin test that was positive, then that patient was administered antenatal corticosteroids and observed on labor and delivery. So at the basis, I will just point out one thing with respect to the study. This center had a very high rate of preterm labor. We do know, like we had said, Mayo Clinic is a very busy tertiary referral center, and their preterm labor stat was 17%. So how did this protocol actually function? What were the results? What this protocol saw is if you kind of followed the algorithm and ended up at the end and were found to find the recommendation that we should be discharging our patients home, what this study showed is that less than 1% of patients ended up delivering within 7 days following their initial evaluation. And ultimately, at 14 days post-evaluation, almost 98% of patients remained pregnant. So believe in the protocol, following the algorithm and following the recommendations. They actually managed to decrease their admission rates by 56% and save their healthcare system almost $40,000. In fact, this protocol ultimately ended up becoming a formal department policy and is the one that they actually follow at the Mayo Clinic. So I will say a standardized algorithm does have benefit. It kind of uniforms, allows a uniform management of patient and allows us to really maintain that we're not forgetting anything and implementing the right methods at the right time. So in conclusion, I kind of like this SMFM statement in June 2022. I think it summarizes it well. Among patients with preterm labor, short ultrasonographic cervical length, cervical dilation, cervical change, and cervical vaginal fetal fibronectin correlate with the probability of delivery within a few days and may help inform the timing of antenatal corticosteroid administration, as we have just proven. Fetal fibronectin and cervical length offers the best prediction of true preterm labor. We need to be using objective test results to help discharge patient, not a subjective and very variable digital examination. And we need to use objective tests showing that the patient has unlikely chance of delivering within 7 days and used to guide our intervention timing for improved neonatal outcome. And lastly, standardized objective preterm labor assessment provides the best patient care. And I just wanted to give a quick word on World Prematurity Day that occurs every year on November 17th. Thanks.
Thank you, Dr. Cassir, and thank you everybody for joining today.
Thank you very much.